we start with this topic of genomic tools and clinical decision. I've kept the slide extremely simple, so if you feel that this is like a daily mundane thing, you will have to bear with me. So the questions regarding these tools are why. So the short form of JEP is gene expression profiling, whichever way you want to say. Question which popped up in my mind was, why do we really need them? What is the data behind them? Now, the kind of patients that they have enrolled is what we get in India or not? And anyway, is the data really exciting? Can we get away with something else? And then Dr. Manjari would be talking about her thing. So I just thought there'll be a thought in my mind about Indian Oncotype DX. She may not like it to call it Indian Oncotype DX, but well, is it very well validated for use? Because whenever patient talks about it, then I have this thought in my mind that anyway, I don't use too much, but is this very well validated? I'm sure she will like to answer that. Why do we really need expression profiling? People, Dr. Doval sir, Dr. Spruti would realize 2000, there was a comment that all tumor more than needs chemotherapy, and some people had to leave NCI because of this statement or the other statement. So one should remember this statement. We all know that this is a huge overtreatment. To treat all more than zero point 0.5 or more than 1 centimeter, to my mind, is a huge overtreatment. I am sure everybody agrees with it. We know that most of the patients actually don't need chemotherapy. Definitely a large majority of ER positive population, excluding HER2 positive population who have gotten early breast cancer, actually don't need chemotherapy. If you look at the Cochrane analysis, early breast cancer trialist group analysis, then the incremental benefit is only 7 to 8% in overall population. So the large majority don't need. So that's probably the need of finding out who to do and whom not to do it. That's why so many JEP tests came into picture. We know about Oncotype DX, we know about ProSigna, we know about Breast Cancer Index BCI, EndoPredict, and also the MammaPrint trial. All these JEP profilings have actually now included the clinical parameter to make it potentially more effective, automatically saying that you can't just do these tests irrespective of clinical profile. But anyway, these are the common tests. I'll talk about very few expression profile, and I like to talk about what is there in my mind about the same. So let's talk about this Oncotype DX Taylor X trial, which, if you remember, had 1 to 5 centimeter as an enrollment criteria. They had to be node negative. They were estrogen receptor positive, HER2 negative. And you know that that was a large population. That will be an aim for Dr. Manjari. Do we have that much of a study said? So there were two arms largely. We'll talk about this arm and then we'll talk about this second arm, low risk and the high risk or intermediate risk. So in the low risk, they wanted to see whether if somebody who has a recurrence score of less than 10, and that's about 16% of population, please remember this number, what happens to them? This is relatively old data now. Now we know that these patients are able to achieve a long disease-free survival, 50 months, 60 months, that's approximately 5 years, of 93.8%, and it will be definitely difficult to add anything substantial to this 93.8, suggesting that if you have an Oncotype DX score of 10 or less, that's less than 11, then you possibly can get away without chemotherapy. Let's look at who are these patients who have an Oncotype DX score of 0 to 10. These are largely a very young population, very few who are elder population. These are largely who have tumors of T1B and T1C size. C is 61%. So we have older population, we have 1 to 2 centimeter population, we have very few patients who are high grade, and surprise, we have hardly any patient who is progesterone receptor negative. So in a sense, you have an elderly lady who has got a grade 2 or a grade 1 tumor, who has a strong ER positivity, who has a strong PR positivity also. We're not talking about 0 by 8 or 2 by 8 PR positivity. And somebody who has a very small tumor of 1 to 1.5 centimeter. If Dr. Doval is there, then one would realize this data set coming from him. If you look at the total population, this is not what we normally have. We normally have something like 3 centimeter to 5 centimeter, and at least less than 2 centimeter, very few. We tend to have grade 2 and a higher grade 3 population. That's an average calculation. And then we have largely aged population and younger population, unlike the trial in the Taylor X, and we have younger, therefore a high number of, fairly large number of premenopausal patients. So it seems that we have a few subset of population or a small subset of population which would have matched the Taylor X low risk population. So if their number was 15.6%, then I think our number will be like 5% or 6%. So that's applicable to a very small number of population. And do I really need to do an oncotype DX? That's a question which keeps on coming in my mind. If I want to find out these oncotype DX less than 10 or less than 11 population, do I need to do an oncotype DX, or shall I say I should choose a lady who is 55 or 60, strong AR, strong PR, grade 1, grade 2 tumor, and no negative for sure. And I could be like 90%, 95% sure that it would be oncotype DX less than 10 or equal to 10. So it comes to my mind that do I really need a surrogate marker of oncotype DX, or can I just get away with this? So that's the question when this set of population comes to my mind, and I'll raise this point later on also. So in a sense, it seems one could predict this extremely low risk population. I'm not calling it low risk, I'm calling it extremely low risk population. And I'm not sure in the real world that I really need to do an oncotype DX. We and other perform oncotype DX for many different reasons, and I'll allude to that later on. If you look at the second part of the thing, which was the primary study group, in which an intermediate risk group of 11 to 25 were randomized to receive or not to receive the chemotherapy, and you can see that was the largest chunk of the population. Unfortunately, I don't have the curves here, but because this is now a relatively old data, people would remember that as an answer, as a primary analysis of 11 to 25 was addition of chemotherapy does not add anything substantial to these intermediate risk population. Subsequently, they've gone on to do a subgroup analysis and found out that you can differentially weight recurrence scores, and you can differentially weight ages that's less than 50 or a younger population, and you can sieve out the population which can possibly benefit out of this larger group, which otherwise was largely negative. Remember, these subgroup analyses were not the primary aim, and the subgroup analysis should be thought of with a fraught, which they're actually fraught with error. Also, to my mind, this question of intermediate risk is better answered by Mind Act, although again that Mind Act was not supposed to answer this question in the same. Let's look at the Mind Act, because to my mind, this intermediate risk population in which you are thinking of getting an oncotype DX, randomized between chemo and no chemo, and trying to decide that whom should you offer, is actually better answered by Mind Act, to my mind, with all the caveats. So quick about the Mind Act trial. We all know about the Mind Act trial. This group is like oncotype DX less than 11. This group is like oncotype DX more than 25. And this in between group is like that intermediate risk group of oncotype DS. Instead of doing all of them, they had this good definition of clinically low, genomically high, clinically high, and genomically low. What is most important here is this group, which is clinically low and genomically high, was actually a part of the oncotype DX intermediate group, and that I will come to, because it seems that if the patient has a clinically low risk, that's like oncotype DX Taylor X trial. According to the Taylor X trial, if genomically high, then you can offer chemotherapy. But according to MINDAC, if the clinical risk is low, irrespective of genomic low or genomically high, you will actually not give chemotherapy, because just a matter of just before I give the answer to that, this MINDAC population was actually much more clinically risky. They had a high population, they had a node positive population of 20%, and even then, the patient who had genomically high, clinically high and genomically low, there was no actual difference in response to the chemotherapy, suggesting that if the patient has a clinically low risk, that means some of the patient in intermediate risk population, genomic profiling does not at all help, which is unlike the between column of the Taylor X trial. So that gives me a more leverage to use or not to use the imprint scoring. Um, so one of the proposed use of print can be that if your patient has a low clinical risk, there is actually no need to do a genomic profiling, because if it is genomically low, you will not need chemotherapy, And unlike Taylor X, even if it is genomically high, then you can get away without chemotherapy. On the other hand, if you have a clinically high risk population, there is actually more likelihood of a use of genomic imprinting, because if there is a clinically high risk patient, which is like node positive patient, higher grade population, and if there's a genomic low imprint, you can actually not overtreat this patient by having a genomic imprinting. So therefore, that's possibly the place in my mind where I think the utility of gene expression profiling is. I would not like to offer a gene expression profiling to a clinically low risk population, which is an oncotype DX population. I would possibly offer a genomic profiling to somebody who has a clinically high risk population. I'm itching to give them chemotherapy, and I think it is inappropriate to give them chemotherapy because that guy got a mama print score to me and said, sorry, it is a genomically low imprint. And I would say, yes, my clinical impression was wrong. And genomically, you have a low risk. You can get away without chemotherapy. And therefore, you can prevent a lot of chemotherapy. A question most often touted by Sudeep Gupta is that, do you really need to go for these fancy, glamorous, costly tests, or do you have an alternative? We always look at our report and look at the ER, the PR, the Ki-67, and HER2/neu immunohistochemistry. And Ki-67 is always a questionable thing of well done, not well done. But in the hand of a good pathologist, when used a very complicated pathway, therefore it is a difficult to use in clinical practice. But having said that, if you look at 25 percentile or a 75 percentile, and this is between 0 and 0.15, and it's not 0 and 100 or 0 and 10, you can see that there is hardly any risk. What can be predicted by recurrence score can easily be predicted by a very good pathologist using an appropriate algorithm, using simple ERPR, HER2/neu, and IHC4. The problem is that these algorithms are not financially viable for many companies. So there's nobody who's going to develop this algorithm and tell the clinician that please don't spend 4,000 US dollars and you can actually get away with this answer. So it's an orphan looking for a parent. So, so, sorry. So, very fast. So what does it answer in the real world and the clinical world? When I practice in my real world, I end up with this confusion, and I hope some discussion over the table will answer this confusion. Seem to have a lot lesser very good risk early breast cancer. So our overall need for expression profiling is much lesser than the need of expression profiling in the Western community. I would agree with it that the need for increasing the need of these patients, or the number of these patients, are steadily rising in obviously very selected population, the equivalent to oncotype DX10. I can predict this population by extremely few number of very good risk patients. And I don't know whether I should be using a recurrence score on them or not. We use it often or rarely, or some we use more often. I'll come to that. These low risk patients in MINDEC actually do not benefit from additional chemotherapy. Even if they are slightly higher risk according to MINDEC population using adjuvant online, if their genomic high risk is low, they don't even benefit even then. So why don't I restrict these tests, whether it is Oncotype DX or MINDEC, in early breast cancer, but which are clinically high risk, like MINDEC? So I would say, why use it at all at low risk? Why not use it at a relatively high risk? Obviously, I do not know whether I can use an Oncotype DX and MINDEC interchangeably. I get to do an IHC4, and I don't know how to do it, but if I can do it, then I think, and if people...
Amit, you have 1 minute left.
Okay, so I can get away with it. And the cost of JEP is too high. I can do chemo for 2 patients. Oncotype DX is a good idea. I do not really know to use GEP, so I don't know how to use Oncotype DX. I need to know how this trial was run. Did they use the adequate number? Was it validated? Was it randomized? And possibly more questions. Last line in my mind, we all seem to have an opinion when we see the patient, and we have already made up our mind that this patient needs chemotherapy or not. Surely no one wants chemotherapy and over treatment is there. Sometimes this test provide numbers like 26. If it was 25, I won't give chemotherapy. 26, I won't give chemotherapy. It's confusing. I think the reason why we do Oncotype DX is basically because there are a lot of medical legal issues, and this often forces decision. The doctor next door, if I don't prescribe, would possibly prescribe and highlight that that doc did not do it. Also, patients do not want their decision. They want us to decide, and they don't want to participate. And that, unfortunately, often, for the safety sake of my future and my practice future, we often say, go ahead, get a RS score, and I will answer you better. Thank you.